Kia ora koutou, no mai haere mai to tonight's Goodfellow webinar. My name is Katie McCulloch and I'm a nurse practitioner working in Tamaki Makaurau. Tonight's webinar is a Te Tiri Whakāro Sharing Knowledge, a webinar series aimed at primary care and supported by Health New Zealand and Te Whatu Ora. Our first session is on weight management with Dr Rinki Murphy, who will discuss practical aspects of weight management, followed by a session on gout management where Professor Stamp will discuss recent evidence for the best management of gout. And then we have our standing segment of clinical updates with Dr Sue Tutty. Our first speaker tonight is Dr Rinki Murphy. She's an Auckland-based endocrinologist specialising in diabetes and obesity. She's also a professor of medicine at the University of Auckland. Thank you so much for joining us tonight, Rinki, and I'll hand over to you.
Kia ora koutou. Good evening. Thank you, Katie. Really pleased to join you all tonight. Updates on weight management. I work at the University of Auckland part-time, Auckland Diabetes Centre and Te Manakatua Specialist Weight Management Service, Te Whatu Ora, Health New Zealand, Counties Manukau. And I'm also part of the Morris Wilkins Centre team of researchers who I'm connected with. These are my disclosures. So why is losing weight so difficult? Well, we know that the central nervous system, we're involved primarily to protect against weight loss, whilst it's relatively permissive for weight gain. And what we find that with meal frequency and size, any efforts to reduce those, we have an increase in hunger and a decrease in satiety from the gut. And therefore, there's a brain-gut axis in weight regulation that we understand from knowledge from bariatric surgery, where various types of gut rearrangement can boost satiety signals and make people feel content for longer with smaller quantities of food. We also know that there are a range of weight loss medications that have been targeting that satiety signals, particularly in recent times, with liraglutide being the first of the GLP-1 receptor agonists approved for weight management in 2014. And we'll be familiar with using liraglutide approved for the treatment of type 2 diabetes. And since then, in 2021, there was semaglutide approved as Wegovy for weight management, and more recently, Zepbound as tirzepatide for weight management, both as GLP-1 and GIP agonists. And so overlaid on this homeostatic system is a non-homeostatic eating, and that interacts with our permissive physiology to add to obesity in some people. So we have this pleasure center and motivation and habit context, food cues, sociocultural factors with emotional eating, episodes of restraint and binge eating, disordered behaviour, addiction particularly to ultra-processed foods, heavy intake of sugary drinks and foods that can all really add to the complexity of weight gain. We know that the convenience and taste and relatively low cost of ultra-processed foods that have long shelf lives enhance overeating, and some really carefully controlled inpatient studies demonstrated this really well. And here they kept they compared ultra-processed diet with unprocessed diet, and they carefully matched for the calories, the sugar, the fat, the fibre, and the macronutrients in terms of carbs, protein, etc. And even in such carefully controlled matching, the ultra-processed option allowed people to have greater intake of about 500 kilocalories of passive overconsumption, even in a 2-week period with a 2 kilo difference. Now you can see in the real world environment that this would layer on with early exposure to ultra-processed foods in childhood for many, many years, and then compounded by the macronutrient distribution, which is also known with less satiating foods that have low fibre, low protein, and so high in fats and carbohydrates, driving the overeating. So practical tips for weight management really are still around the 6 A's, as it provides a good framework in many of the obesity management guidelines, starting with asking for permission to discuss weight and exploring readiness for change. It's a very loaded subject, and there is a lot of stigma around weight. And so there are some suggested phrases I've put here on the right, and really making that time, particularly in another appointment, to talk about this might be something to consider, and engaging with motivational interviewing, asking for what people have tried in the past, what's worked, what's not worked, and then moving into assessment of the of weight. Less so about obesity class and stage, but more around complications, advising on the different methods of management and what types of long-term strategies might work, agreeing on a treatment plan and assisting and revisiting that whole cycle repeatedly. So assessing for barriers, this is a piece of research done by Audrey Tay and Hannah Hoeksema, dietitians, around what's published in the qualitative research around what are barriers and facilitators of weight loss. And many people who have experienced weight loss successfully find that very motivating in of itself. Self-monitoring, restructuring the food environment are markers of self-efficacy, and engaging in a program which, for example, may have meal replacements over challenge of making food decisions can work for some people, supervision, accountability, and social support. But there's a range of barriers as well around cultural expectations of refusing foods, locations, triggers for eating, and reduced time for physical activity and regulating emotions without food, and a lack of a rescue plan or support for weight regain. And I was also quite interested in the altered eating behaviours in people with obesity, and a strategy on assessing for those is through an 18-item questionnaire that compresses the questions required to ascertain night eating, sweet eating, food addiction, particularly for ultra-processed foods, hyperphagia or binge eating. And these are assessed in terms of frequency, and any frequency more than more than once a week on a regular basis for 3 months can be classified as an abnormal eating behaviour, and it's not apparent by the class of obesity or without doing this questionnaire how some people may have multiple abnormal eating behaviours. A third of people have 1 or 2, and a third of people don't have any. And the people with complex and multiple eating behaviours will need more support and tend to be those who don't respond to simpler strategies. Now, assessing for clinical obesity recently has moved away from simply BMI thresholds of 30 being class 1, 35, class 2, 40, class 3, and rather there's an idea around firstly assessing whether somebody has got obesity, not just limited by BMI. So if you have someone with a BMI over 40, then that's safe to assume that they're carrying excess body fat. But if they're lower than 40, then applying ethnicity-specific thresholds and including another anthropometric criteria is needed according to the latest definition of diagnostic criteria of clinical obesity this year. So for us, this has those thresholds for Pacific, Māori, European for the differences in body composition, and lower thresholds for Southeast Asian and Chinese. And these need to be combined with 1 or 2 anthropometric criteria if people don't meet the BMI threshold. So the anthropometric criteria include waist to height ratio of above 5, or an increased waist circumference, or a body fat percentage by DEXA. Then once that is met, so if people do fulfill the criteria for obesity, then there's the search for whether or not there are alterations of organ function in order to classify clinical obesity and prioritise treatment for people who have clinical obesity rather than preclinical obesity in terms of the intensity of the interventions offered. Now, there's a range of features that we're all aware of, the mechanical ones relating to urinary incontinence or knee and hip joint issues or obstructive sleep apnea. And there are the metabolic issues that often we need to screen for with our lipids, liver function, renal and diabetes screening, but also the cardiovascular and reproductive components and limitations of daily living. In terms of assessment, a new feature has been the recognition of severe pediatric onset monogenic obesity. Now, these are very rare conditions, but is worth noting if you do have somebody who's got with a pediatric onset of BMI above 24, which is above the 99.9th percentile, if you see in the grey here. This is worth referring on to endocrinology for assessment, and particularly given that there is a new treatment that's been FDA approved called setmelanotide, an MC4R agonist, that we may be able to access on a compassionate basis and best explored by endocrinologists, both pediatric or adult. And this medication acts downstream of these monogenic conditions, either where leptin acts in the central nervous system in the hypothalamus and interacts with the MC4R receptor and triggers satiety. The other referral to consider is for endocrine investigations if you do spot features of acromegaly that can be subtle, including weight gain and coarsening of the facial features, amongst others, and spot diagnosis on the right, Cushing's with particularly pigmented and broad striae. Anything over 2 centimetres is pretty suggestive of Cushing's disease, so it's something we screen for in our clinic. In terms of the next day, which is advising on obesity management options, we've had very little between, in terms of funded options, between Tier 1, Tier 2 and Tier 4 bariatric surgery, which is a very constrained resource. And in terms of lifestyle management, the sort of healthy plate model and healthy heart from the Heart Foundation and other resources are there, but they have a very modest effect on obesity itself, and it's more about weight management to prevent further weight gain rather than an actual treatment. It would be unlikely to cause significant weight loss. In terms of the next tier of strategies around medications, these have been unfunded and remain so, including the availability of meal replacement products, and purchasing these without being part of a structured meal replacement program offers less benefits. So in terms of setting up a specialist weight management service in counties and Mangere, I was really thinking quite a lot about the Tier 3 specialist weight management service and what components we could include. And the most potent non-surgical options were a structured meal replacement program and the adjunctive use of naltrexone, bupropion or liraglutide at the time. And this we've switched recently to semaglutide, and we could only really make it a viable option up to a sort of a 3 to 6 month period in those people who weren't able to respond to meal replacements for the two aims of remission of type 2 diabetes or to access elective surgery procedures with a lower weight limit. And initially we set out to invite people who would decline for bariatric surgery, and since then we've opened up to secondary care referrals only rather than to primary care at this stage. Now, the theory around intensive meal replacement programs are that they can reduce cravings, hunger, and have improved satiety because of ketosis, and the less food-related stimuli that's required in the intensive level means that sometimes those cravings can be limited because of that very narrow window narrow types of foods, and the convenience of the time-based intake of meal replacements. And there's some practical, helpful skills around low-starchy vegetable meal preparation, and this can be returned to for future weight regain once people have practiced that. And we had consumer group consultation for this, as well as a parallel co-design. We were gifted Te Manakatua as the name. The Power is Beyond, and had considerable support from many people in terms of stakeholders in establishing the service. So our initial results align well with the published results of meal replacement programs, with a look-ahead study that was delivered in the community with meal replacements, as was direct study in the UK, which was a primary care intervention. Diadem was in secondary care, and clearly Te Manakatua was in secondary care. We had a much more complex group of patients who had high number of comorbidities and a higher BMI than other published studies, and we offered support in a group fashion plus individual support, with about 8% mean weight loss at 6 months if we use last observation carried forwards. But in the people who remained in the program, there was 35% diabetes remission at 3 months and 48% at 6 months, in line with other studies, but there is attenuation of that over time. In terms of the medications that we have in New Zealand, we now have more than we used to. So Orlistat is the only over-the-counter option, and has steatorrhea and oily spotting, so it's not really very well tolerated. Phentermine can be useful for people who with a lower, it has a lower cost, depending on dose. I find 15 milligrams even on alternate days seems to work well for some people, and is off-label use for ADHD. And screening people for that can sometimes help in selecting the appropriate medications. We don't have Quercemia, but this is the combination of phentermine topiramate, and we can actually prescribe topiramate off-label for weight management in addition to phentermine, but it's also funded for migraine, so it can make for a very cost-effective option. It does have teratogenicity, so we do need to ensure contraception. Contrave is another oral option. It's about $200 per month. Liraglutide is now being largely replaced by semaglutide, or Wegovy, as of July 2025, with a similar cost of $500 per month, and approximately plus pharmacy markups. Constipation, dyspepsia, vomiting, nausea are all very manageable side effects, particularly with careful dose escalation and advice around foods that are less fatty or spicy, and having smaller portions. And tirzepatide, or Zepbound, I understand will be available in 2026 with a price point that's comparative to the semaglutide. And what's really exciting is that these second generation, or these newer medications, have double-digit mean weight losses, 15% for semaglutide, 20% for tirzepatide, so really are very impressive results. And we have a long history of knowing about them. Initially, exenatide was first approved for type 2 diabetes in 2005. We haven't had it funded for only since 2021, so quite a long delay for us to have it funded in New Zealand, and really coming from the Gila monster saliva gave biochemists the opportunity to use that as a template to derive more and more powerful GLP-1s. So liraglutide and semaglutide have been chemically engineered to have a longer lasting impact. Now, they do have impacts on the central nervous system to reduce food intake, but also amplify the glucose-stimulated insulin release in the pancreas, and reduced gastric emptying. So both portion size control and return of hunger after meals is lowered, and there's a less food noise and less snacking behaviour observed with people who are treated with with either GLP-1 receptor agonist or the dual agonist, which tirzepatide also has a benefit with increasing insulin sensitivity in the adipose tissue. Semaglutide is hitting the headlines because it is the first treatment that it was approved by the FDA for people at high risk of major adverse cardiovascular events. And they, in the SELECT trial, the primary endpoint of 20% reduction in MACE was found in people randomized to semaglutide. And so this is a pretty impressive result, similar to statin and blood pressure reduction. So this is a really good indication alongside weight management for using semaglutide. It's also effective in chronic kidney disease, 24% reduction in major kidney events, heart failure with preserved ejection fraction. So not much not to like about semaglutide. Tirzepatide is also being tested in a range of studies, some MOUNT studies showing almost 19.7% weight loss, so 20% weight loss is found. And with this extraordinary weight loss, you also get the reduced risk of developing type 2 diabetes in those who are allocated this treatment over 3 years. Tirzepatide has been shown to be helpful in MASH, in sleep apnea. So the first medication to be approved for obstructive sleep apnea by the FDA was tirzepatide. And when we look at the potency of these GLP-1 receptor agonists in terms of lowering appetite, then potentially what is the impact of additional behavioural support? Well, if we look at the liraglutide studies with the number of lifestyle visits were 12 visits per year, so monthly behavioural support sessions around diet, physical activity, compared to studies that incorporated more than that. Wasn't too much more mean weight loss seen with more intensive support, but the baseline was pretty heavy at 12 visits per year. Monthly sessions are the norm for semaglutide studies, and the more intensive support didn't produced small and incremental gains with going heavier in the intensity of the behavioural support. Now, tirzepatide is only in its studies offering lifestyle support every 12 weeks. So that's the kind of norm that we'd have to see to at least mimic those results in the real world. It remains to be seen whether most of the real-world studies show much lower impacts, so that just remains to be seen. If we look at bariatric surgery trends in New Zealand, these are looking like sleeve gastrectomies are becoming the more predominant type of procedure, and they are variable with respect to the different DHB areas, and this trend is likely to be similar given the post-COVID impacts on elective surgeries. There seems to be a similar number in private as in public. When we compared in a randomised blinded controlled trial, the surgeons weren't blinded, just the assessors were blinded, to which procedure the people received, it appears that people with type 2 diabetes and obesity have more durable and longer weight loss and type 2 diabetes remission after the more complex Roux-en-Y procedure compared to the sleeve gastrectomy, and my 10-year results have just been published showing the durability out to 10 years, particularly with Roux-en-Y gastric bypass. And their mean starting BMI was 42. This is not without complications, and the risks of early minor complications and major complications are similar, about 5 to 10% minor complications, about 5% major complications, which are things that require return to theatre or hospitalisation. And later minor complications with food bolus obstructions or other strictures and stenoses are also seen, as well as ulcer perforations. So if we could return to finish off in terms of practical tips for weight management, regardless of the intensity of the weight management tool used, whether it's bariatric surgery, medications, there is the need to have some behavioural goals and matching that with individuals is key in assisting with drivers and barriers when looking at strategies such as self-monitoring, stress management, ways of creating other ways of managing emotions than eating, stimulus control, and removing the ultra-processed foods and sugary drinks, and behavioural substitutions are all key for getting the most out of any intervention. So with that, I'd like to, I'll stop there and really keen to take some questions.
Brilliant. Thank you so much for that, Rinki. That was great. I will jump straight in. What are your thoughts on the GLP oral supplements that are being advertised? I feel, I guess the supplement industry is very unregulated, and I guess people are utilizing things that are saying they are GLP supplements. What are your thoughts on those and people using them?
I don't think that they've been rigorously tested. I'm not aware of any supplements. I must say that I had a deep fake made of me apparently endorsing certain products, including some GLP ones that were not at all what I would class as the approved medication. So nothing over the counter if you're talking about those products, that I would be familiar with the rigorousness. I'm not aware of those in any of the clinical guidelines.
Okay, thank you so much. And why can you speak to why GLP-1s are not advised to be used in type 1 diabetes?
I think the idea of using it for weight management alongside having type 1 diabetes is fine. So provided the starting criteria are met for the goal of treatment being weight reduction and then the attendant sort of reduction on the total insulin daily doses, that's not a contraindication. It just wouldn't be a insulin, people would remain as requiring insulin.
When you're prescribing phentermine and topiramate, what doses do you recommend starting on?
So I'd start low and go slow. I would go 15 milligrams of phentermine on alternate days, and then add in topiramate starting at 25 milligrams at night with its sedating effects. And then I'd assess that at 1 month. Sometimes I would increase that dose of topiramate to 50 milligrams at the 1 month mark, and keep the phentermine at alternate days or even daily doses. So sometimes it's really important to ask patients how they're feeling on the days on or off, and then going to the daily tablet if they find that that's beneficial.
Is there still a worry around the addictive potential of phentermine? And how long would you consider continuing it for?
So it's not been shown to have an addictive potential. It's mainly the monitoring of blood pressure and pulse, and in younger people in whom they don't have cardiovascular risk factors, that can be useful whilst that's being monitored. And there are some long-term safety data to show that under monitoring of those parameters and checking for cardiovascular risk factors, people can use it for prolonged periods. It's a negotiation between the more expensive medications that can be safer on multiple fronts with multiple comorbidities. But yeah, in young people, that's a fine option.
Someone's written here, "Hi Rinki, brilliant presentation. I have a Māori young male in his late 30s that had good weight loss post-sleeve surgery, lost 30 kgs from 145 kgs, but is now gaining and is seeking Duramine to come off the cravings. What are your recommendations in this situation?"
Post sleeve or bypass surgery, the studies are showing that GLP-1s can actually really help with cravings. I'm not aware of phentermine, but it's worth just trying and seeing for a response for a cost effectiveness basis. But it's really interesting how the studies that show post-bariatric weight regain can be for multiple drivers. If it is the return of hunger, the slowing down of gastric emptying from the GLP-1 seem to be quite helpful, because both the sleeve and the bypass are speeding up gastric emptying, and so sometimes the cravings and the snacking behavior can come back.
So really appreciated, Rinki. Thank you so much for your time tonight. We're moving on now to our second session with Professor Lisa Stamp. She's an academic rheumatologist at the University of Otago and Te Whatu Ora, Waitaha, Canterbury. She's also the National Clinical Research Lead for Health New Zealand. Lisa is the director of the Canterbury Rheumatology Immunology Research Group, and she's speaking to us tonight on gout management. Thank you so much for being with us here tonight, Lisa.
Thanks very much, Kate. So yeah, I'm going to talk tonight about gout management in 2025. You'll all be aware of how important gout is here in New Zealand. It's estimated to affect nearly 6% of the adult population. And Māori are twice as likely, and Pacific peoples are 3 times more likely to have gout than non-Māori, non-Pacific peoples. We know that gout causes significant morbidity and impacts just about every aspect of life. So really, I think we can think of gout in these stages. There is a stage where people have a normal serum urate, they've got no disease. Then we move through to an asymptomatic stage where people might have hyperuricemia, so a high serum urate. With advanced imaging techniques, we've been able to show that they might have monosodium urate crystal deposition. They actually haven't presented with a gout flare or with tophi. And during these 2 phases, obviously urate-lowering therapy is not recommended. A proportion of patients with asymptomatic disease will move on to symptomatic disease, and this consists of the gout flare, which we all see so frequently. And some patients will move on to having chronic gouty arthritis and tophaceous gout. And during the symptomatic stage of disease, we do need to treat the gout flares as they occur, and for most people, urate-lowering therapies are recommended. Now, it's important also to recognise there are a number of comorbidities associated with gout. Rinki's talked about obesity. That's a known association with gout, as is hypertension, hyperlipidemia, cardiovascular disease, and hypertension, so the metabolic syndrome. And comorbidities associated with gout, it's important that these are identified and managed as appropriately. Now, there are a number of gout flare management strategies, and I'm not going to go through this in detail because I'm sure you're all very well aware of how we manage the gout flare. I think it's important just to note that early administration of whatever anti-inflammatory therapy you and the patient have chosen is important. Our first-line therapies are typically colchicine or NSAIDs, corticosteroids, typically if patients can't have either of those. And the choice of the agent is really dependent on the comorbidities, concomitant medications, and previous experience of efficacy and side effects. I think it's really important when patients have flares that we start to talk to them early on about the concept of gout as a chronic disease due to monosodium urate deposition, and that we do have the potential to dissolve the crystals and improve clinical outcomes if we use long-term urate-lowering therapy. And so I think really early on, we need to start talking to patients about that concept. Now, as you'll be aware, long-term management of gout is critical. And the rationale for long-term therapy needs to be explained to patients. We know that if we can reduce serum urate to below our treatment target of less than 0.36 millimoles per litre, that gout flares will settle and that tophi will resolve. So their clinical symptoms will definitely get better. I think there's some really critical things about starting urate-lowering therapy that we need to highlight to patients. And one is that there is a risk of gout flares during initiation of urate-lowering therapy. This is not an uncommon referral for us. My patient can't tolerate allopurinol, and when you go into it, it's actually because they've flared when they've started urate-lowering therapy. There aren't too many conditions where you give the patient a medication and say, I'm going to give you this treatment, it's going to help you, and then the first thing it does is actually make them worse. So we need to prepare patients for that, and we need to discuss with them about anti-inflammatory prophylaxis during that early period of urate-lowering therapy. I think it's also really important to talk to patients about time to achieve the target urate. Um, it does take time, probably on average 6 to 9 months to reach target urate. And during that time, they will continue to have flares, and so they need a flare plan. And even once they've achieved target urate, it does take time for the flares to stop. So we really need written, personalised instructions for each participant. As I'm sure you're aware, the indications for urate-lowering therapy are multiple. These include having 2 or more flares over a 1-year period, having gouty tophi, radiographic damage due to gout, and/or kidney stones. The anti-inflammatory prophylaxis that we use, we typically recommend this, as I said, in the first 3 to 6 months when starting urate-lowering therapy to try and prevent those early flares. The colchicine and naproxen would be, or an NSAID would be the top ones that we would recommend at low dose. There's the odd patient that does require long-term steroid. These tend to be the more complicated patients that we see in the secondary or tertiary care setting. I think it's important to recommend to realise that there's not a one dose fits all for urate-lowering therapy. So allopurinol is the first line therapy worldwide, and we do need to adjust the dose in a systematic fashion to achieve our target serum urate of less than 0.36. And as I said, it can take up to 6 to 9 months for this to come together. So I think those are concepts that you're all familiar with. At least I hope you're all familiar with. But so what I want to now spend just a little bit more time on is what's new that we should be thinking about. And I think there are 3 things that I really wanted to highlight in this talk, and there's 3 references there that you can get some more detail on. And the first is what is and is not allopurinol failure. And then I want to talk about this concept of the post anti-inflammatory prophylaxis flare blip. And then finally, just the place for SGLT2 inhibitors in gout. So allopurinol failure, and I put that in quotation marks, is a common reason for referral, both for inpatient referrals and outpatient referrals. And these are kind of things, these are direct quotes taken from referrals that we've had. Allopurinol's caused gout flare. My patient still got gout despite being on allopurinol and at target urate. My allopurinol is not suitable as my patient has renal impairment. Allopurinol just doesn't work. And so these are all people saying that allopurinol treatment has effectively failed. Now, the reasons why a drug fails are complex, and they can really occur at any point in the therapeutic chain. And that's the process describing the life of medicines in the community. That includes everything from manufacturing of drug, which is not a problem for us because we have a good supply. This can be more of a problem with people getting buying online medicines overseas and getting fake medications. Through to the diagnosis, that we actually prescribe the medication, that it's dispensed. And then the 2 things I've highlighted there in red, which are very important with allopurinol and other urate-lowering therapies, is getting the correct dose and then adherence and persistence with treatment. And if all of those things get right, hopefully we get the desired clinical outcome. But sometimes we don't get the desired clinical outcome, and sometimes we have an adverse event. And those latter 2 are really what I think of as a drug failure. So I think the first thing is to think about is my patient's taking allopurinol, but they're not at target serum urate, because just being on allopurinol is not going to stop gout. You actually have to achieve the target serum urate. And there are 3 concepts to this. The first is allopurinol dosing. There is a wide dose range for allopurinol, ranging from 50 up to 900 milligrams daily. There's no one fixed dose that will allow the majority of people to reach target serum urate. And so it really does have to be individualized. There's a lot of underdosing in the community, and we see that frequently in hospital as well. We know that the allopurinol needs to be systematically increased, and renal function is not a contraindication to that. So if serum urate's not achieved with low dose, then you do need to increase it to the maximum approved dose, which for us is 900 milligrams, or the maximum dose the patient can tolerate. Now, allopurinol adherence and persistence is a massive problem. We know that irregular allopurinol prescribing is a barrier to treatment success, and we know that health systems are poorly resourced to manage chronic care for gout, for people with gout. So we do need systems to ensure regular prescribing for allopurinol and to build an understanding about gout as a chronic disease of monosodium urate crystal deposition that we can effectively treat if people persist with treatment. Now, there is a very small group of people who really don't respond to allopurinol. It's probably about 10% of people who have the dose systematically increased won't achieve target serum urate. So I think my first question when I see somebody who hasn't achieved serum urate is really about adherence. Are they taking it every day? How many days are they missing? And importantly, what are they doing when they have a flare? And we often find that when people have a flare, they stop their allopurinol and then they start again when the flare's over, and that can be 2 or 3 weeks. So they're never really getting to a period of sustained urate reduction. I think the other thing in that setting, which is just a real trap for some players, is that the serum urate does drop and can drop well into the normal range, i.e. below 0.36, even down as low as 0.3 during a gout flare. So and that's often the time when we measure it, because the patient's sitting in front of us, so we see them and then we give them a form and have a blood test. But the blood test comes back and they're below target. That might be a false low reading. So we do really need to make sure that we get some accurate readings away from the time of a gout flare. And then I think the second thing is really about what if we fail to control flares despite getting serum urate down to target. So I think the first thing is just to think, have we got the correct diagnosis? There are flare mimics. Other types of crystal arthritis, such as pseudo-gout, can look just like gout. And we know that chronic gouty arthritis can mimic rheumatoid arthritis and psoriatic arthritis, noting that you will get a high serum urate in psoriasis due to the increased skin turnover. So I think it is important just to review the diagnosis if the clinical outcomes don't improve as you expect when you've reached target serum urate. As I mentioned before, flares when you start urate-lowering therapy are common. They are not specific with allopurinol. In fact, they're even worse typically for patients who start febuxostat. So if that's what is being considered to be allopurinol failure, then anti-inflammatory prophylaxis is required. If you switch to a different urate-lowering therapy, you're still going to have the same problem. And we do need to talk to patients about the potential for this and give them an action plan and a ready supply of flare medication, as we would for patients with diabetes or asthma. And then we also have this group where we have continued gout flares despite being at target serum urate. And I think it's important to realize that there's a significant time lag. So you can continue to get flares for up to 12 months after you get to target urate. Again, this delay is not specific to allopurinol, and it represents the time for clearance of the monosodium urate crystals. So we do need to make sure that our patients are aware of that, that they have a flare plan. And discontinued gout flares, despite being at target, is not an indication to change to an alternate urate-lowering therapy. Clearly, if drug failure is due to an adverse reaction, that does require change to an alternate drug. Just a note of caution, there can be some cross-reactivity between allopurinol and febuxostat. So if they have had a reaction to allopurinol, there's a slightly increased risk that they'll get one to febuxostat. So the second thing I just wanted to mention briefly was the post-prophylaxis flare blip. And this was really an unexpected finding from a study that we undertook here in New Zealand, which was a randomized controlled trial of low-dose colchicine versus placebo as anti-inflammatory prophylaxis for 6 months in patients starting allopurinol. And we started with the recommended start low, go slow dose escalation strategy. And we showed clearly in the first 6 months that colchicine did lead to suppression of gout flares. However, unexpectedly, after the colchicine was ceased, we saw this rise in gout flares that you can see here. So at months 7, 8, and 9, they had an increase in gout flares. And that was really quite unexpected. We went on to do a literature review and meta-analysis and confirmed this in other trials throughout the literature, where you see this post-flare, this post prophylaxis blip in the number of flares occurring after the colchicine's been withdrawn. And so I think we really do need to be aware that this can happen. We need to caution our patients about the risk of flares after that period of prophylaxis is stopped, and make sure they do have a good, clear plan and a supply of their medication. There might be some people who are flaring a lot in that 3 month, or the months after stopping the anti-inflammatory prophylaxis, and in those people I'd probably consider just going back on the low dose prophylaxis for a further period before trying to withdraw it. We're not entirely sure of the mechanism of this. It's potential. I suspect that colchicine has a number of anti-inflammatory effects, and when we withdraw it, it kind of takes the brake off and allows a more pro-inflammatory state to occur. There will still be crystals in the joint at that period, and so it just allows those flares to sneak back in. Now, the final thing I wanted to talk about is the role of SGLT2 inhibitors in gout. I'm sure I didn't hear Rinki's talk, sorry, Rinki, but I'm sure that that these were mentioned in the setting of weight loss. But we know that these have got multiple other clinical effects other than the ones that these were initially used for in terms of improved glycemic control. So they can lower blood pressure, improve renal outcomes, and improve cardiovascular outcomes. They can contribute to weight loss. And so they are a really attractive adjunct therapy for people with gout who've frequently got metabolic comorbidities. And the question's really arisen, do they actually have a specific role in gout management? So I think the data on this is all from secondary analyses of RCTs, but these secondary analyses have shown consistently reduced risk of incident gout with the use of SGLT2 inhibitors. So if we look at this, just one example here of the dapagliflozin trial. This is a post-hoc analysis of 2 phase 3 clinical trials that involved about 11,000 patients with heart failure. Dapagliflozin reduced the initiation of uric acid lowering therapy by 57% and treatment with colchicine by 46%. Now, these trials did not collect gout outcomes such as flares, so those outcomes weren't systematically recorded. So we are reliant on medication dispensing. But it does give the sense that they might reduce risk of incident gout. Then the second question has been, can they prevent recurrent gout? And there's been some large population-based retrospective cohort studies using the UK primary care database. So these have included nearly 60,000 people with gout and type 2 diabetes with visits to their GP. And initiation of an SGLT2 inhibitor has been associated with about 20% fewer recurrent gout flares. I think it's interesting to note that the SGLT2 inhibitors weren't associated with an increased risk of flare that I've already described, that we see when we start other urate-lowering therapies. So you can see this reduced incidence here in the graph. The other thing that has come to light is the effect of SGLT2 inhibitors on serum urate. And so secondary analyses of studies in type 2 diabetes and heart failure have consistently reported a serum urate lowering effect of SGLT2 inhibitors And the degree of effect of reduction does vary. We tend to see a larger reduction with a higher baseline serum urate, a larger reduction in those who don't have type 2 diabetes. And there does seem to be some difference between the different SGLT2 inhibitors, with empagliflozin having a bigger effect than canagliflozin or dapagliflozin. Whether this urate lowering effect varies depending on renal function is less clear. And then because the SGLT2 inhibitors increase urinary uric acid excretion, so a bit like probenecid, we might wonder whether there's an increased risk of renal stones, as we see with other uric agents. The difference with the SGLT2 inhibitors is they also increase urinary flow and cause osmotic diuresis. And so the data is really reassuring that the risk of kidney stones with SGLT2 inhibitors is not there as it is for the other uric agents. I think there's a couple of caveats to this data. Most of it is from most of the data on serum urate reduction is derived from secondary analyses of studies for diabetes and heart failure. And the magnitude of effect is in people with comorbidities on serum urate reduction with and without gout does require more investigation. But I think this is really encouraging data that these agents can have a benefit for our patients. And you'll know, that, as I said before, that there are a number of comorbidities associated with gout, including diabetes, high BMI, and cardiac problems. And so the beneficial effect of the SGLT2 inhibitors makes these agents a particularly attractive potential treatment option for people with gout. And certainly, if you're treating these comorbidities, then you may want to think about the role of an SGLT2 inhibitor and the add-on effect it may have if they've got gout. So where could these SGLT2 inhibitors have an effect? Well, I think they could have an effect here at preventing first gout flare. They could have an effect at helping reduce recurrent gout flares. They may have a benefit on urate lowering for people who need that, and they'll definitely have a benefit on the comorbidities associated with gout. So there's a number of steps in the management process where they might be beneficial. So really, just to wind up, then I think that it's really important that we acknowledge that these general principles of gout management, as I've talked through tonight, we don't typically treat asymptomatic hyperuricemia. We need to treat the gout flare promptly with an agent that we've agreed with the patient. We need to think about urate-lowering therapy with a target serum urate of less than 0.36. We definitely need to think about anti-inflammatory prophylaxis when people are starting urate-lowering therapy to try and prevent gout flares, but we need to be aware of the post-prophylaxis blip. These patients should all be screened for the comorbidities that we've discussed, and I think it's really important that we spend a lot of time trying to educate our patients about the rationale for urate-lowering therapy, the risk of flares, and that they have a really strong action plan for flare management and a ready supply of the medication so that they can start to self-manage. And this is very similar to what you all do for other conditions such as diabetes and asthma. So with that, I'm going to stop, and I'm happy to take any questions.
Brilliant. Thank you so much for that, Lisa. When do we consider an extended course of prednisone, and what's your recommendation as to the dose of this?
I think one of the problems with prednisone I see is that patients are given very short, sharp courses. We don't like to use prednisone. We're all very aware of the potential side effects with long-term use of prednisone. But I think that gout flare, one of the problems we can see is if it's reduced very quickly, you can get a rebound flare. So they get treated well, but they have this short course, and then as soon as the prednisone stops, the flare is allowed to escape again. So I typically wind them down over a couple of weeks. I know that sounds like quite a long time, but I typically wind them down. I tend to start with a dose of 20 and then go to 10 and then go to 5 and then stop over 2 weeks. If 20 is not enough, can go up to 40. It's a very, again, it's what the patient has had experience with before that's worked. And I think we do always just need to bear in the back of our minds these mimics. And so it's important to recognise that gout and septic arthritis can coexist. And so if the gout flare is not responding as it typically responds to the treatment that you've used in the past for that patient, just to rethink, are we sure this is gout? Do we need to aspirate the joint to make sure they haven't got concomitant infection?
Occasionally, we get new patients who were started on febuxostat overseas without even trying allopurinol. Do we just continue with the febuxostat, or should we switch to allopurinol?
Technically, you should ask the government or Pharmac whether they can have it, because it's like many other drugs that are funded overseas that are not funded here. It's under special authority still. And so generally what we find with other drugs like the biologics is Pharmac won't necessarily fund them if they don't fulfill the New Zealand criteria. I think you've got a good rationale for asking Pharmac. Just do a waiver and say they come from overseas and ask. It would be pretty disappointing for them to have to change, but I guess you do have to be prepared to sign the special authority form saying that they've filled the criteria.
Do you recommend anti-inflammatory prophylaxis if subsequently up-titrating the allopurinol?
And I've talked a lot about anti-inflammatory prophylaxis, but not necessarily if I'm just they've been on it for a long time and that they're, you just need to do potentially a few dose increments. I don't necessarily put them on anti-inflammatory prophylaxis. I don't use anti-inflammatory prophylaxis with everybody and that's mainly because a number of the patients I see, prednisone would be the only drug that would be safe for them to have. And I don't really want to commit somebody to 6 months of anti-inflammatory prednisone if I don't have to. So I often have quite a detailed conversation with the patients about pros and cons. I think the other thing too is if you look at that culture scene data, actually there was no difference in flares over the whole 12-month period. So you could either have your flares early if you didn't have anti-inflammatory prophylaxis, or you could have them late if you had colchicine and then had to withdraw. So it kind of evened out over the whole year in terms of the numbers. So I'm not saying don't use it. I think there are key groups that I absolutely use it. That's young people who have had a flare within the last couple of months or are currently having a flare. When I start them, they absolutely should have anti-inflammatory prophylaxis. If they haven't had flare for yonks, sometimes I just talk to them about it. Well, let's see how you go. If you're having lots of flares, then we'll start.
Brilliant. Thank you so much. That's all we have time for, unfortunately, with the Q&A. I really appreciate you giving your presentation tonight and answering all the questions. We will now move on to our final segment of the night with Dr Sue Tutty with the clinical update segment. Thank you so much, Sue. Lovely to have you here with us again tonight.
So there's quite a lot I wanted to talk to you about because this is our last meeting for the year and it looks like 2026 is going to be an exciting time for primary care. I wanted to start with just this registering on health pathways for your individual accounts, and I know that you will have all seen this when it came out because it was sitting on our pathways for quite some time before we got to actually use that. And I just want to show you, I'll just go back a slide. Why we should do this is obviously for health pathways, it lets them know who's using which page. And so it lets them know which pages are more effective or being used more, and also the effective education programs that they might run. But for your sake, it also allows you to collect CME points on your usage. So if you're on health pathways, and you can see by that red arrow that this says that I'm logged in here. It's got my initials or my name at the top on that right-hand corner. Many of you are probably logged in under your PMS systems in your practices already, and so it will be a generic login rather than your own name. So if you want to log in under your own name and be able to collect the CME points, then just click that downward arrow up in that right-hand top corner, and you need to sign out, which it shows you in the bottom screen, a sign out, and then you will go to the welcome page on the top right of my screen, and it says sign in at the bottom of that page to register, and there's the sign in page, and that can get you to be able to record your own usage. And then if you want to collect your CME points, you go to that same drop-down arrow on the right, and instead of going into sign out, you go into manage account. And then once you're in manage your account, there's that blue spotted area on the left-hand side there on the left bottom screen. And you click on that and it will open up, and it actually opens up to all the pathways around New Zealand. So if by any chance you wanted to just have a look at what they're doing in another part of the country, or to see if they've got a pathway that's different to the one that you're used to using, then you can have a quick squizzy on that. And then, but if you're wanting to do your CBD reporting, then you click on that, the arrow top right, it shows you where to click. And then you can create a new report of your CBD monitoring, and that gives you the amount of time that you spent on each page. And that's measured from when you open the page until you stop moving your cursor around it. Now, a little bit about abnormal uterine bleeding, because this is a big piece of work that's come out to primary care, and about the guideline, which is going to be published at the end of this week. So you will be aware that there's services funded within your district if you already had services there, and it's now available with no priority populations or restrictions on it, but universal coverage for women. It's aimed at those districts that don't have that aren't able to claim for AUB services and pelvic pessaries will be able to claim by the end of March. There are training modules. The pessary one is now up and available on Ko Awatea Learn or Health Learn, depending on what part of the country you are in. And the AUB one will be up shortly, again, hopefully by the end of this week. And the National Health Pathway, so the pathway that is with the national guideline on it is completed. It's just waiting for the localization for each region. Our health pathways teams have been so busy doing all the changes for the radiology work that came out before this, and so there has been some delay in getting the health pathways up, but we hope that they'll be there very shortly. And I just wanted to mention a little bit about the new AUB guideline, because it's quite a change in practice from what we were doing previously. It does give consistent management across New Zealand, and it gives a clear definition of what AUB is. And holistic management, it includes a section even on affirming women for their decision to come in to be seen, because we've heard a lot of women are doubtful whether what they're experiencing is abnormal uterine bleeding or not, and are slow to present for care, whereas they're putting up with huge morbidity, which we could help them with, really. So there's quite a bit of advice on medical management and up titrating your progesterone doses, lifestyle management, to provide more comprehensive care, and the ability to access Pharynject too for people. And then the indications for papal biopsy and hysteroscopy, which are quite different from what was previously done in New Zealand, particularly for our younger women, where we're starting to see more cases of endometrial cancers in the under 35-year-olds, and that rather than using age and endometrial thickness, using risk factors is so much more important, such as BMI, PCOS, diabetes. And also a recognition of ethnicity variations in the incidence of endometrial cancer, to the extent that through the guideline it's made clear that investigations to exclude endometrial hyperplasia or endometrial cancer should be considered at or soon after the initial presentation for all Maori and Pacific peoples. So ultrasound is no longer the first line investigation. And the other thing that is new in the guideline is about the primary care management of endometrial hyperplasia without atypia. This is just there as something some people may like to do. It's not there as a compulsory thing because it does imply that you're going to take some care with some governance over this, really. Now, Pharmac, the supply issues, just to do an update, the oxycodone, everybody was asked to move to the liquid when the immediate release tablets were in short supply. Now we're vice versa, and we need to move back to the tablet formulation, please. Podophyllin, there is a French product that's available now while we're waiting for the shipment of the Condoline. So the French packaging is section 29, whereas when we get the Condoline back in January, that will be just normal prescribing, and that the brand of enalapril is changing from the 1st of December. Methylphenidate we've been talking about all year, I think, and Pharmac has been working really hard to make sure to reduce the supply issues as much as they can. So they have a new brand that will be starting on the 1st of December. It's not quite made it into pharmacies. It's still probably coming into wholesalers about mid-December. And this is similar to Concerto and available in all strengths that is. And this is to help us prepare. So this is one of the exciting changes that we're expecting in February 2026, when health professionals, including GPs and nurse practitioners, are able to prescribe ADHD stimulant medicines. So I've just put this slide in, which I've used a few times over the last year, but just showing you where this new product, Sandoz XR, which I've marked in red there, fits in with the extended release, the 12-hourly release of methylphenidate. Also in blue, if you'll notice, there's a new product that is coming that's just gone out for consultation, and it's proposed to be here by the 1st of July, which is Rubifin long-acting, which is the same product really under a different brand name as Ritalin LA. So from the 1st of December, Pharmac has made changes to special authority approvals, and this is for insulin pump consumables, CGM monitors, the LAMA-LABA inhalers, erythropoietin, budesonide capsules for Crohn's disease, and febuxostat, so that there's no longer the same need to renew the special authorities. And this isn't really in preparation for the 12-month prescribing that is also coming on the 1st of Feb. They looked at these prescriptions and saw that the special authorities were really just administrative, and it would reduce their workload by about 20%. So I think everybody wins, and it will help with the uninterrupted funding of these treatments, especially once we're on 12-month prescribing. And the last Pharmac update is for estradiol patches, and we'll be moving back to just the two brands of estradiol, TDP, Myland brand, and the Estradot. And the other brands will be delisted from the 1st of December. So looking forward, the section on system change. So it's things I've already given a quick mention to, the 12th month prescriptions by the 1st of February. And there is some guidance out on this now, which the College of GPs has put out, and saying how clinical judgment must be applied to this. They recommend in-house policy, that we consider equity and access and work collaboratively with pharmacists, because we know that there are some people, and they've listed the sort of people who this might be a concern for, where the shift may reduce opportunities for clinical review and the risk of delayed interventions and leading to poorer outcomes unless there are appropriate safeguards in place. So everything has benefits and risks. We can see the benefits of reducing barriers to access, with limited opening hours, wait time to see GPs, closed books, the cost, and less time required to obtain care if you can do a 12-month script, and improved adherence is less gaps between prescriptions, and it may lessen inequalities, but in the same light, it may also reduce monitoring of side effects, which may worsen adherence, and it may widen health inequities just because of the reduced monitoring of patients and the lack of opportunity to consult on the medications. So 12 months prescribing is a way forward, is, as the college suggests, make a policy as a practice so that everybody knows what the policy is. Use your clinical judgment. But more importantly, I think involve your patients in shared decision making so that we're not going to lose trust with our patients, that we explain why we want to see them back, perhaps. And you might consider doing a 6-month script instead of a 12-month one. Capitation reweighting is something we've already talked about in this group. That will come out from the 1st of July, but already they're starting to get this organised with the new formula so that it can be worked out give it time to be worked out by July. And we talked about how the old one was just based on age and sex and hasn't been changed since 1990s, whereas deprivation, rurality and multimorbidity will now be included. And it may include other funding that has also been available to primary care. Some practices may see funding increase while others see it decreased, but there is work being done on targeting mitigation for those affected practices. And as with anything, it's very hard to get it perfect the first time, so this will be renewed after 2 years and then every 5 years. ADHD, again, 1st of February, this change will come in place so that that GPs and nurse practitioners are able to prescribe it. There's been work done on a clinical principles framework, and it's expected that no one will be prescribing medications for ADHD without fitting with this clinical principles framework, and that there is training that is going to be put in place for that. So certainly the College of GPs supports this. It estimates that it would be at least 1 to 2 hours of work, which doesn't fit into a normal GP consultation. And so it needs to be worked up as a different way of working than a normal GP practice. And lastly, I just wanted to mention EPCC, Extended Primary and Community Care, because this is another big piece of work. It started with AUB and cellulitis, but I'm sure that there's more to come. It's providing standardized funding and work in progress for practice-to-practice referrals, and maybe workforce development for funding for training. So lots of exciting things to come in the new year.
It's excellent. Thank you so much, Sue. Really appreciate your clinical updates as always. There's just some comments around the big issues in primary care is the funding for these AUB guidelines and the ADHD, which, we're all aware of the limitations of the funding, unfortunately. And there's just a bit of, I guess, a discussion around the 12-month scripts as well, and how it's going to be navigated with patients in practice. So hopefully there'll be some support and guidance and some patient or consumer facing information to reduce the maybe conflicts that may occur with patients asking for medications when we want to look after them and make sure that we're not, we're keeping those checks on.
So I would certainly advise people to go to the College of GPs website. I've put the link there on the slide, and to look at what their advice has been on some of these issues.
That is all we have time for tonight. I just want to say thank you so much to all three of our speakers for joining us and sharing your knowledge and all the mahi that you're doing. To those of you watching, thank you for joining us and being with us tonight as well. Ka kite, everyone. Have a lovely night.